Thank you. Here is the link to the Wordly app in the chat for live translation, again, if you would like to listen to the webinar in a different language. And so today, I'm pleased to welcome Trish Coffey and Samuel Kabonge, Philippi Malumba, and Betsy Wilski from PATH on behalf of the Amplify project. So I will turn it over to you, Trish, to kick things off.
Thanks, Laura. Thanks so much to everyone for spending some time with us today to hear a bit about strategies to improve access to quality assured PPH medicines in the DRC. I'm Trish Coffey, and I lead our commodity access work at PATH under the Amplify project. And the bios of the other three presenters were included in the invite, so I will let you refer to that. We won't have time for each person to introduce themselves. We have quite a lot of information we'd love to share with you today. Next slide, please. So the Amplify project, oh, we're just trying to get the slide moved here. Sorry about that. The Amplify project is the Accelerating Measurable Progress and Leveraging Investment for Postpartum Hemorrhage Impact project. This is a Unitaid funded project, and it is led by JPIGO, who is also responsible for the first objective there of generating evidence. And then another consortium partner, FIGO, is responsible for creating an enabling environment. And PATH, the third consortium partner, is responsible for preparing the market. So our target products are all postpartum hemorrhage medicines, including heat-stable carbetocin, tranexamic acid, and then misoprostol for advanced distribution for self-administration. The target countries of the project are listed there. We are specifically speaking just about activities in the DRC today, but similar parallel types of activities are ongoing in India, Kenya, and to some extent Guinea as well. The exchange countries are listed there. They are more of recipient countries that where we're sharing learnings with and helping them to advance their best practices for postpartum hemorrhage management as well. Next slide, please. So I'm sure with this group, we don't really need to go over this slide, but just a brief reminder of the WHO recommendations related to the drugs that are recommended for using for PPH prevention and PPH treatment. Of course, for PPH treatment, we're looking at the uterotonics, including oxytocin, carbetocin, including heat-stable carbetocin, misoprostol primarily are our drugs of interest. And then for PPH treatment, looking also at oxytocin, misoprostol, but more importantly, as a new and underused drug in the PPH management space, tranexamic acid, or TXA. Next slide, please. So at PATH, in terms of our commodity access work, we really look at it from sort of an interrelated strategic approach, where we see availability, pricing, and quality all as being important aspects to be able to achieve improved commodity access. I think in terms of availability, people are very aware, and according to the RHSC's Elite Maternal Health Report, in fact, we can see that there is a big gap in availability of these medicines, with 69% of cases in sub-Saharan Africa being estimated to need misoprostol and oxytocin, not getting it, and also only a small proportion of cases that need TXA receive it. In terms of pricing, we're really trying to focus on looking at pricing mechanisms that can help achieve affordable and equitable access to quality assured product, both for consumers, but primarily for health systems. And we will share a bit about our work around that today as well. And then we will also be noting some work that we're doing in terms of quality. I think we're all aware that, especially in low and middle income countries, quality of these PPH medicines is a concern. And we cite just there a couple of studies that show that there are quality concerns with uterotonics as well as with TXA. Next slide, please. So today we're going to talk a little bit about some of the activities that we're doing in this commodity access realm, starting in 2023 with work we're doing around availability, where we assessed availability and pricing, moving to 2024, where we worked on exploring price mechanisms, and we'll talk a little bit about that work, as well as some work around modeling tax reform to achieve more affordable pricing, particularly on the consumer end. And then moving to looking at building skills and value-based procurement as a way to achieve quality assured procurement of these PPH medicines into the supply chain. So with that, I will turn it over to Kibange, who will talk to us a bit about availability. Kibange, over to you.
Thank you, Trish. So I'll take us through the availability and pricing for DRC. But before that, I think I'll be able to give a background that we conducted pricing and availability survey in 4 countries, that is Kenya, India, DRC, and Guinea. And the main objective for the survey was to understand the pricing and availability for the 4 medicine. And the medicine for focus are misoprostol, tranexamic acid, oxytocin, and histobocapetocin. And the methodology used borrowed a lot from World Health Organization and the Health Action International methodology. So then we'll go deep dive into DRC and look at the survey areas. We focus on 3 areas: Kisantu, Kimpese, and Kinshasa. And a total of 63 facilities were surveyed, 19 of them being public health facilities, 20 being private for-profit health facility, 12 for private non-profit health facility, and also we surveyed 12 pharmacies, private pharmacies. Next slide. So we'll start by looking at the first medicine, and it's oxytocin. I look at this availability by area and facility type. And one of the findings that we found was that the oxytocin availability was high in all types of facilities surveyed. However, availability in pharmacy in Kinshasa was lower compared to other areas. Next slide. So we also looked at the average facility procurement prices by area, and we looked at the price for oxytocin per ampule, and the price here is in USD. And as you can see, the highest facility procurement price was observed in Kisantu, especially in public and private non-for-profit facilities. And then you can see for Kisantu, for public health facilities, it was averaging around 0.17 USD. Next slide. The next medicine was misoprostol. In terms of availability, on average, stock availability for misoprostol was lower at health facilities compared to pharmacies in Kimpese, and no stock was available in private facilities in Kisantu. And as you can see, for Kisantu, the private for-profit health facilities, the stock was not available. Next slide. In terms of the average facility procurement price, the misoprostol average procurement prices varies depending on area and facility type. As you can see, if you look at Kimpese, the average facility procurement price was around 0.79 for public health facilities. And if you look at Kisantu, for the public health facilities, was averaging around $0.39. Next slide. So the third medicine of focus was tranexamic acid. In terms of availability, tranexamic acid availability was low at the surveyed sites compared to the other medicine, and TXA was not available in public facilities in Kimpese and Kisantu. Next slide. So in terms of facility procurement for tranexamic acid, there was no significant variation. However, we did not have enough data to make comparisons. So much as we wanted to compare tranexamic acid, we didn't have enough data to give that comparison. Next slide. The last medicine of focus was histobocarbetocin, and at the time of survey, the histobocarbetocin was not available. However, it was later introduced in 2 health zones, Kimpese and Kisantu, in December 2023. Scale up is ongoing right now to additional health zones, and we hope that the availability will be more in the scale up zones. Next slide. So finally, what were our key learnings? Number one is stock availability of oxytocin was high in surveyed areas and sites. However, availability of misoprostol and tranexamic acid were lower compared to oxytocin. The other learning was that stock availability of misoprostol was lower at health facilities than it was for pharmacies. And Kinshasa sourced the PPH medicine from private distributors as compared to the other 2 survey areas that primarily procured from public procurement entities. And lastly, the average facility procurement price varies depending on facility type, as we have seen in the presentation, and survey areas. So it was not constant, but varied depending on the areas and facility types. I think then the next slide. Then I will have to introduce my colleague, Felipe, to take us through the pricing aspects. Over to you, Felipe.
Thank you, Kibunge, for the floor. So now I'm going to take you through the PPH medicine pricing workshop. Next slide. So before that, we need to remind that medicine pricing is complex, and the medicine price can be determined directly by fixing a maximum price or statutory discount. It can also be determined indirectly by regulating the profit or by negotiation via a value-based approach, and also by a competitive tendering and bidding mechanism. So the medicine price can be influenced by several factors, such as the pricing policies and choice of approaches, selection and procurement policies, and other policies such as intellectual property, industry, and competition. So there is not a single mix of methods and policies. The priorities for a country might vary depending on the budget, the demography, the burden of disease, and the strategic importance for local industry. So it is important to understand different options and approaches and how they interact in order to ensure policy coherence. The selected approach and method must be locally tailored, transparent, and stable, also predictable. Next slide. So the WHO has developed guidelines on country pharmaceutical pricing policies. These guidelines describe several methods and approaches toward implementing a medicine regulatory framework, and also described case studies of countries where these methods have been implemented. So for our workshop, we reviewed these guidelines and organized and convened a 2-day workshop in Kinshasa to initiate discussion with key stakeholders. Next slide. So the workshop was held in July 2024, and we brought to the same table key stakeholders involved in decision-making regarding medicine pricing. We had to the table the Ministry of Health, the Ministry of Economy, and the National Committee for Universal Health Coverage, and the National Regulatory Authority. These bodies are involved in decision-making for regulating the medicine price. Apart from them, we also had bodies involved in the supply and procurement of medicine, such as the National Drug Supply Program, and the Federation of Essential Medicine Procurement Agencies. Next slide. So the workshop objective was to engage discussion or dialogue about price mechanism with a focus on PPH medicine. And specifically, we aimed to develop an understanding of current country plans and regarding pharmaceutical pricing, and share WHO guidelines on pharmaceutical pricing policies, and discuss the advantages and disadvantages of each methodology. We also aimed to discuss the feasibility of each pricing mechanism to the DRC context, and co-create a roadmap for country implementation of select pricing mechanism. Next slide. So, no, you have skipped one. No, you have skipped one slide. Yeah, next. Yeah. So the workshop started by giving some fundamentals. The Ministry of Health and Ministry of Economy gave some presentations on current policy and strategy around pharmaceutical pricing. And this was followed by the introduction on WHO guidelines on pricing methodologies. So we specifically discussed on the external reference price, which consists of referring the price of medicine to the price in pre-selected countries that are called reference countries. And the internal reference price is the practice of setting the price by comparing the product with therapeutically equivalent medicines. And the next was the margin regulation and price transparency. Here, a markup is applied to the price of the product to cover overhead, distribution, cost, and profit. The last one is the value-based pricing and health technology assessment, which is a pricing technique that aims to set the pharmaceutical price according to the measured and quantified value that patients and healthcare systems attribute to a pharmaceutical product. Next slide. So after this background and the introduction of the WHO guidelines on pricing regulation, participants were divided into small groups with a balance between expertise. We had clinical, policy, and procurement expertise, and each group was assigned a pricing methodology and given the WHO guideline on the method, along with 2 case studies for review and discussion. So after the group work, each group reported to the plenary a summary of the pricing method, lessons that they have learned from the case study, and the appropriateness of the method to the country context, and the challenges and opportunities that they have identified to implement the method. And the group discussion were used to inform interactive exercise to develop a roadmap for country implementation of select pricing mechanism. Next slide. So as key highlights, the National Council for Universal Health Coverage and the Congolese Authority for Pharmaceutical Regulation conducted analysis on the potential impact of tax reform for medicines. A critical next step is to establish an interministerial committee to develop tax reform policy and implement standards and guidelines. The DRC have implemented a markup policy for medicine pricing. However, there is a need to reinforce and to include the regressive markups other policies such as external reference pricing and internal reference pricing was found suitable to be associated with the markup policy. The value-based procurement was identified as relevant intervention, particularly in terms of PPH medicine procurement. And also participants identified that stronger data infrastructure is critical to ensure accurate price data are available to move the use of pharmaceutical pricing to the implementation phase. Next slide. So here is the roadmap that was created in the workshop. So on the left, you have areas where the participants thought are critical for strengthening the pricing ecosystem. And on the right, you have short, mid-term, and long-term activities that need to be implemented before to ensure the implementation of the pricing regulation. So, for example, here regarding the tax reform, on the midterm, the participants thought that it is important to advocate for lower costs and changes on imports of life-saving drugs for women and children, including tranexamic acid and its tetrodotoxin. And on the mid and long term, it was important to create an interministerial commission to regulate taxes and profit margin. For the procurement and supply chain, in the midterm, they found important to strengthen the central purchasing unit capacity for value-based procurement, and for the midterm, to implement the value-based procurement and implement existing guidelines for good distribution practice. So this is about the pricing workshop. Now I'm going to take you through the tax reform activity that we conducted. Next slide. Next. So this activity was conducted in collaboration with the National Regulatory Authority, ACOREP, and the objective is to analyze the impact of tax and duties on government expenditure on medicine, to analyze the impact of taxes and duties on out-of-pocket private sector medicine price to patient, and generate evidence to support continued dialogue by the Interministerial Commission on implementation of a tax reform. Next slide. So we conducted interviews at two main entry gates, Kasumbalesa, which is a land gate, and Matadi, a sea gate. We conducted these interviews with custom agents and brokers, 5 each at both sides. So we collected data on taxes, duties, and other administration fees from 5 shipments of oxytocin. Data are to be analyzed using ACOREP method to model impact of multiple tax reduction scenarios on product cost. Next slide. So for information, the taxes and duties are calculated based on Ecoterms. And here we have presented for information the CIF, which is the cost, insurance, and freight, which applies to the sea and inland watery transport. And it includes the cost of goods plus insurance and freight until they reach the port of destination. So the global standard is that taxes and duty on imported goods are calculated based on the CIF value as declared on the shipping document. Next slide. So here we present the preliminary data. So we have all the taxes and duties, and fees that are collected that were collected on oxytocin shipment and presented as percentage of CIF. As you can see, the total taxes cover 44% of the CIF value. So this is higher compared to other countries in the region where you found the country that the taxes cover 0% to 6%. Next slide. So next step, we will complete the analysis of the impact of taxes and duties on government expenditure on medicines that are currently under validation and not available publicly. And ACOREP will submit recommendation to the Interministerial Committee for tax reform and engage discussion with the government for a progressive reduction strategy. If the strategy is found sustainable, further reduction can be considered. So thank you for your attention. Now I'm giving the floor to my colleague Betty to speak on the value-based procurement workshop.
Thank you, Philippe. Next slide, please. As Philippe shared, an activity identified on the pricing policy roadmap was to strengthen capacity for value-based procurement. I will present the approach and outcomes of the resulting value-based procurement discussions in DRC. However, I would like to begin by defining what exactly is value-based procurement. Next slide, please. Value-based procurement, or VBP, is the practice of evaluating potential products, services, and solutions to maximize overall value for money rather than focusing only on the lowest purchase price. There's often a mistaken perception that procurement is only a compliance-driven, time-consuming, and administrative function, and not an opportunity to drive value-based healthcare. We need to change that narrative. Value for money is central to the development of health policy and the delivery of healthcare. A healthcare system that delivers value for money is defined as one that maximizes efficiency, enabling the population to attain the highest possible level of health given the level of expenditure. VBP is one mechanism to help ensure we are delivering value for money. VBP is conducted using the same core principles as traditional procurement: integrity, fairness, and transparency. But instead of the goal being to minimize price or minimize the cost, the goal of value-based procurement is to maximize value. How is this done? It can be approached in several different ways, but the key is multidisciplinary coordination between healthcare providers, policymakers, procurement teams, and a clear definition of value criteria, such as economy, efficiency, effectiveness, equity, and sustainability. Next slide, please. VBP is not one size fits all. It may differ between countries and even between products, but there are three foundational building blocks necessary for successful implementation of VBP. Number one, laws, policies, and guidelines. Public procurement policy must allow for evaluation of value for money rather than lowest purchase price. While many, and I would go as far as saying most, public procurement policies do allow or stipulate value for money analysis, public procurement teams are often unable to target value for money within existing evaluation systems, which still tend to focus on lowest price. Number two is mechanisms for multi-sectorial and multidisciplinary collaboration. VBP cannot be conducted in a vacuum. It requires coordination and communication with clinical, quality, procurement, and financial experts, and in some cases, even civil society or even suppliers. And the third building block is whole of government data systems. VBP is a cycle whose goals is to continuously improve. Ideally, VBP is conducted in an environment where data to inform procurement decisions is available. As an example, supplier and product performance should be monitored, documented, and used to inform future procurement. Next slide, please. So how do we define value? Value criteria are different for different stakeholders. Stakeholders may have an incomplete picture of requirements. Payers may only be looking at short-term budget impacts. Procurement staff may not have long-term visibility on all the uses and specifications. Physicians may be unaware of some costs, such as disposal costs or cold chain costs. Also, stakeholders change throughout the product life cycle. For equipment, biomedical engineers may look at the national standards and availability of spare parts. Clinicians may prioritize features that increase compliance. Policymakers may prioritize things like green packaging or local manufacturing, and patients may prefer a combination or extended release formulation. Next slide, please. Because value can vary so different across stakeholders, we need to clearly define value so that quality criteria can be quantified and used as part of the tender evaluation process. The first step to doing this is to define value criteria by 5 broad categories. They are economy. Does the medicine provide required health services at the lowest total evaluated cost? Efficiency. Does the medicine maximize patient, clinician, or health system benefits relative to other alternatives? Effectiveness. Can the medicine effectively contribute to better health outcomes? Equity. Does the medicine support the health needs of all populations? And finally, sustainability. Can a health facility, program, or system supply and maintain medicines long-term? Next slide. So how do we put this all into action? Let's look at some specifics. As I mentioned before, VBP is not one size fits all. You can implement any or all of these approaches independently of one another. I will not go into detail on all of these examples, but I want to highlight the examples that we explored during the workshops in DRC. So first off, strategy. When we approach strategy with a VBP mindset, purchases are driven by long-term evidence-based strategies. Focuses on value for money. Sometimes this may mean a longer procurement cycle of 2 or 4 years. Compared to traditional procurement, which may be ad hoc, not driven by strategy, focuses on purchase price, and short-term needs or arbitrary timelines. Secondly, the market approach. VBP is informed by collaborative engagement with potential suppliers. It identifies long-term supply chain risks. Oftentimes, procurement teams are hesitant to engage with suppliers outside of the formal tender process, but this can result in incorrect assumptions and failed tenders. Pre-tender market engagement can and should happen in a fully transparent manner, which complies with procurement policy. Comparatively, in traditional approach to procurement, there is a lack of supplier engagement and no evaluation of supply chain risks. Moving on to technical specifications. When conducting VBP, technical specifications are finalized with a multidisciplinary team early in the planning and acquisition process. Comparatively, many times in a traditional approach to procurement, they are drafted late or many times as almost the final step with minimal input from multidisciplinary voices. And then finally, we looked at bid evaluation and adjudication. Under VBP, value criteria are identified, justified, and evaluated by a multidisciplinary team. And ensure that they will deliver value for money. For medicine, this should include testing and quality requirements, in some cases also for active pharmaceutical ingredients. Comparatively, bid evaluation in traditional procurement focuses primarily or exclusively on purchase price. Next slide, please. So now that we have established what is VBP, Let's put the discussion into the Congolese context. At the end of November last year, a multidisciplinary group, many of which also attended the pricing methodology workshop that Philippe described earlier in the year, we gathered in Lubumbashi to discuss value-based procurement. The workshop was led by the National Drug Supply Program, or PNOM, and participants included clinicians, pharmacists, regulatory and quality assurance experts, procurement experts, and academia from across the country. As you will see, the key to this meeting's success was bringing the correct mix of expertise together for dialogue and decision-making. Next slide, please. The overall objective of the meeting was to initiate a multidisciplinary conversation towards adoption of VBP, with a focus on medicines to prevent and manage postpartum hemorrhage. Specifically, the meeting used facilitated discussions and presentations and small group work to support national decision makers to define an approach to implement VBP practices for PPH medicines in line with the country's current procurement system. Specifically, we focused on product technical specifications, quantification, quality assurance testing, and tender evaluation using multiple criteria decision analysis. Next slide, please. So, how did we begin? Because the meeting participants represented a wide spectrum of clinical and technical expertise, we began with a series of presentations to ensure a baseline understanding of key topics across all workshop participants. Presentations from all participating agencies summarized current policy and procedures for PPH treatment and management, including updates on training of healthcare workers and status of quantification, procurement, and distribution for heat-stable carbetocin, TXA, misoprostol, and oxytocin. After establishing the status quo, we then moved on to a facilitated discussion on the current quantification methods for PPH medicine, how duplicative processes can better align and ensure multidisciplinary participation. After the quantification conversation, we ended the day with an introduction to value-based procurement. Next slide, please. The second day focused on collaboratively drafting new quality-focused technical specifications for our target PPH medicines. To do this, we began with an overview of current quality control procedures by both ACOREP, the National Regulatory Agency, and FEDICAME, the federation responsible for the vast majority of drug procurement in DRC. These presentations included an understanding of testing protocols, and this was done to better contextualize the QA requirements, which we included in development of technical specifications. The primary technical resource for this activity was the 2022 GHSC Manual for Procurement and Supply of Quality Assured MNCH Commodities. If you are unaware, this is a phenomenal research which contains technical specifications and quality assurance information to support procurement of 12 MNCH commodities, including all 4 amplified PPH medicines. It is available in both English and French. We approached this activity by participants divided into small multidisciplinary groups. Each group was assigned a PPH medicine, either TXA, misoprostol, HSC, or oxytocin, and given the corresponding section from the resource document to use as a starting point to draft a new technical specification. Each group then presented their draft to plenary for further discussion and as edits. This resulted in, at the end of the day, we had 4 new draft specifications with a focus on quality for HSC, TXA, misoprostol, and oxytocin, which were then ready for final review and approvals. Next slide, please. The focus of our final day was on multiple criteria decision analysis for procurement of pharmaceuticals. Where there are multiple suppliers and a medicine is off patent, procurement teams can consider using multiple criteria decision analysis, or MCDA, during tender adjudication to ensure quality and achieve lower prices. MCDA criteria can include quality standards for API and finished product, cost effectiveness, storage requirements, environmental characteristics, including packaging requirements, delivery terms and conditions, supplier history, and also local manufacturers or small disadvantaged businesses. To facilitate this discussion, we used case studies from Egypt, Indonesia, Kuwait, and Thailand, countries which all use MCDA to evaluate some or all of their pharmaceutical tenders. We again used a small group format where each group read and discussed an assigned country case study and then presented how, if the approach could be used in the DRC context. While FEDECAME already uses an MCDA approach, this activity helped to identify additional criteria for consideration. Next slide, please. The workshop ended with development of formal recommendations, which included the specifications for our 4 core products drafted during the meeting should be reviewed by the Directorate of Family Health and specific groups to be finalized, and we expect that to happen in the coming months. Number 2, to update the National Essential Medicines list to integrate new technical specifications for the focus medicines. Number 3, to establish a national quantification committee with multidisciplinary members and to determine the profile of the committee members to avoid parallel quantifications. This is to address a current practice where there's 2 units that are doing quantification of PPH medicines, and this is to bring them together in one so that there's a single activity that a single quantification that everyone agrees with. And this committee should prioritize a new quantification of PPH medicines. The next item was to map the national cold chain capacity to plan for storage of oxytocin where it's being used. And finally, to integrate HSC and TXA into the national DHIS2 and LMIS platforms. Thank you for your time and attention. I will pass back to my colleague, Trish Coffey, to summarize next steps. Over to you, Trish.
Thank you, Betsy. Next slide, please. So our final slide is just really sharing a little bit about what would be the next steps towards improved commodity access in DRC, starting from this year onward. As Betsy mentioned, a critical piece is to update the quantification of PPH medicines so that there's just one single quantification in the country rather than 2 as currently, with maybe potential for more. The good news also is that DRC is forming a new agency, which is going to be called the National Office of Medicines, which is replacing PNOM and will centralize the procurement of health commodities. So that's moving forward. And I should say that these steps are really writ large for DRC, not necessarily related specifically to tasks that the Amplify project can take on at this time, but we are happy to support where possible. And then finally, to support this new agency, ONAMED, to develop robust VBP procedures and continued coordination with FEDECAME to ensure availability of quality medicines. So I think we have about 10 minutes or so for questions or thoughts, comments. We would love to hear anything that you might want to share at this point. So please just either you could write something in chat or take yourself off mute if you have anything you want to add at this point. We really appreciate your willingness to listen to us and to hear about the work that we're doing. Anybody?
I asked a question in the chat, Trish, about regressive margins. I wanted an explanation about that.
Great. Betsy?
Yeah,
Or
I was gonna, if Philippe or I can jump in. Regressive margins are, sorry. Sometimes if you have the same margin on, like profit, allow the same profit margin on everything, right? Then there's an incentive for manufacturers to have higher prices. So the idea of a regressive margin is that you can have lower profit margins on higher priced products to encourage, to encourage lower priced products in the supply chain. Does that answer your question?
Thank you. Thank you. Yes.
Okay. Jane, I see your hand up. Oh, sorry, Trish.
go ahead.
Hi, yes. Amazing presentation. Wonderful. That was really great to hear all of this work that's been going on in DRC, and congratulations to the 3 presenters. That was great. And of course, you, Trish, for taking us through it. There's a lot of questions that came to mind, but in the interest of time, I'll focus on 2 main points, I think, which is about resources that are available. The first, I know, Betsy, in your last presentation, you stressed the importance of a quantification process and making sure that was aligned and so on. Just to alert people that MSH has been working on an update of the RMNCH forecasting supplement. And the update was only on the PPH chapter. The rest of the guide stays the same. But on the PPH chapter, we have made much more purposeful reference to heat-stable carbetocin and tranexamic acid, and also introduced a methodology for forecasting of trays for blood collection, which is a new piece. I know several people on the call have been involved in the consultative review process that we had of that. Just to clarify, I am joining today as an unaffiliated member, but the other members of the MSH team who are finalizing this document will be circulating this guide, hopefully by the end of March, to this wider group. So I make sure that they have all of the email addresses and so on to disseminate that. So that will be available very soon. I think it'll be a useful resource, obviously, for your team in DRC, but obviously beyond that. Given the situation and that USAID projects are no longer doing very much, it would be great if everybody on this call can really make like a concerted effort to make sure that this resource is disseminated and used widely. And the other point was just to talk a little bit, you talked a lot about procurement, and one of the things that you didn't touch on in much detail, or maybe I missed it, was subnational procurement and procurement at lower levels, where obviously capabilities are and capacity are limited. Just to flag in that manual of quality assured procurement for MNCH that Betsy referred to, and I put the link in the chat, there is actually an annex in there that talks a little bit about subnational procurement and different ways of doing that better to take into account some of the criteria that Betsy went through as she talked about BBP. But other than that, great presentation. Just one last question, maybe how long is the project going on for? How much longer do you have?
Thanks, Jane, and thanks for putting that link in the chat and for all of that good insight that you shared just now. The Amplify project will be ending in July of 2026. Currently, the current Unitaid funded project, but I think Naoko is on the call, who is the JPIGO lead on the commodity access piece. So I don't know, Naoko, if you want to add anything.
No, it is the same. So it is scheduled to end at the end of July 2026.
Yeah, so we're hoping that we'll be able to do some more substantial work, at country level throughout 2025. But obviously, as with everything, resources are limited and need to be prioritized. But we are, so, we're happy to have this opportunity to share what we've been able to do so far. Yeah.
Hi, Trish. Unfortunately, I can't raise my hand. This is Jeff Jacobs from others. So can you hear me?
Yes, we can.
Thanks for the presentation to all of you. Just a couple of questions. The data that you guys were sharing around the price, the medicines, oxytocin, heat stable carbon, it didn't provide dosing, so I didn't know if that was 200 milligrams of meso, 10 milliliters of oxy. So if you could comment on what the dosing was there, and then I thought it's really more of a query question. Up front, you identified that the target products were heat stable carbon TXA and misoprostol. But later, you're talking a lot about oxytocin. So I was just curious to know what.
Why?
Yeah, because I thought it was very much focused on sort of new and lesser used, PPH medicines.
Yeah, well, it's a good point. I mean, I think though we can't really ignore oxytocin as being sort of like the most available product currently. And so in terms of our availability, we wanted to assess, using oxytocin sort of as the benchmark to see what were the other products and how available were they. And then I think that at government level, oxytocin has been such a strong, important component of PPH management that, it needs to be discussed as part of our effort around, sort of more writ large PPH medicines relating to both currently used and more underutilized medicines. But I would love Philippe or Betsy to maybe comment on that as well.
Yeah, so of course the target was the four medicines: heat stable carbitocin, tranexamic acid, and oxytocin 10 μg by 10 ml, and misoprostol 200 microgram. So we focused on. So you say we focused on oxytocin for other activities like the tax reform and the pricing regulation. So this is we chose the oxytocin as a tracer just to understand how the medicine are charged at the duty at the custom level, but we could not do all the four medicines regarding the availability of data, because at the duty they have code for a group of medicines. So for oxytocin, it was simple and clearly when you have the code, you know that this shipment is oxytocin. But for misoprostol, it's under a group of medicines, so it might be misoprostol, it might be any other hormones-related medicine. So that's why we chose to go with the oxytocin.
Yeah, understood. Yeah, just was curious. So did I understand correctly? The misoprostol pricing that you identified was the 200 milligram tab. Is that what it was that you showed?
200 microgram, four tabs, yes.
200 milligram tab. That's the pricing that's being shown.
Yes, okay. 200 microgram.
Yeah. Thank you.
Jeff, if you're talking about the availability survey data, which I think is what your question maybe was relating to in terms
Correct.
of that dosing, right? Let me put it in the chat for you. I just want to double check. Okay.
Thank you.
Yeah. Okay, over to you, Laura. I think we just have 1 minute.
Yes, excellent timing. Thank you everyone for your attendance and participation in today's webinar. And thank you to all of our speakers, Kibonge, Felipe, and Betsy, and Trish. It was a pleasure hosting you, and we will be sharing the recording and the presentation in the next few days. So thank you everyone for your time.
Thanks,
Thank you,
everybody.
everyone.
Bye.
Bye-bye.